Okay, greetings. I'm Heidi Nass, and I am here with Monica Gandhi from the University of California at San Francisco and Liz Connick from the University of Colorado at Denver, two clinician researchers that I'm delighted to be talking with about data, presentations, information you saw this week at the Conference on Retroviruses and Opportunistic Infections here in Atlanta. So we're at the end of 3 full days of presentations and posters and data in all forms. So I guess just in general, as clinicians and researchers going to these presentations, walking through the poster hall, when it comes to women living with HIV, whether it's in the U.S. or not in the U.S., what grabbed you, or what do you think is potentially meaningful to your women patients, let's say?
So I think a couple of things stood out for me. One was really somewhat a study that people have been really waiting for, which was this question of pre-exposure prophylaxis with tenofovir and emtricitabine-based regimens in women in a large African study. And knew a couple of things about this study leading in because a couple of the arms of this study, which was called VOICE, had been closed down previously, but this was really the final moment to ask about the combination pill of tenofovir and emtricitabine and how effective it was in HIV-negative women who were given it to be taken every day, and then what about their subsequent rates of HIV acquisition.
So that study had a pill they were taking orally every day to prevent HIV infection. Right. And then there was also an arm that had a gel that they would apply vaginally.
Right.
Every day.
Right.
Right? Okay.
Yes. So there was 2 placebo arms, and then there was a pill they were going to take every day, and it had 1 component in it, and then a pill that they were going to take every day that had 2 drugs in it, and then a gel that they applied vaginally. Okay. And we'd already known previously to this date that the tenofovir gel arm didn't seem to work, and they had to close down that study arm, and the single pill of just tenofovir alone didn't work, so they had closed that down about a year ago. And so this was the long-awaited, okay, well, what happened with the combination pill? And in a nutshell, it was not effective in preventing HIV infection in women who were identified to be at risk. At least they all had to be sexually active, so they had that risk factor. Whether they perceive that they themselves at risk is still being worked out. They didn't seem to perceive themselves at risk, and I think that is what led to.
And the big thing to note is the reason that it wasn't effective, right?
Yeah, which was really that it didn't seem that women were actually taking the pill very commonly.
Yeah, right.
And that was probably
gel.
true. Or the gel, exactly. Yeah, or the single pill. And even though they were saying that they were taking it every day, the way to kind of look at that was to look at drug levels of the tenofovir in the bloodstream, and only 26% of women in the combination pill had drug levels that indicated they had been taking it with any consistency.
And a good chunk had no indication in their blood that they had taken it at any time
at all.
In the last week or something anyway,
yeah.
Right? Yeah,
yes.
So that means they're not taking it regularly or it would show up, right?
Yeah, and I think a lot of it was why it was so important is that I think it's going to just have so many implications for the world of how we inform clinical trial design, because they were saying they were taking it, but they weren't. What was done that could have informed this better? Like what was done about the incentives that women got to participate in the trial versus not? If you don't feel your risk, well, why would I take the pill every day? What was maybe done with focus groups to think how would they wanted this? And the investigators did a great job trying to put this together, but it just didn't work, and it was probably because they didn't take the pill. And that's the important message: is that if you're not going to take the pill, then this is not an effective strategy. Or use the gel.
There's a lot of hope for using something that's that you're not taking a pill every day, that you can just apply. Yeah. I mean, I'm interested, Liz, in what struck you about it, or what any particular aspects of that particular trial and the results, or any of it. I have my own, of course. I want to see if you had any.
Well, I think it shows what we actually know in a lot of situations is that, people don't necessarily like taking pills. And we obviously hadn't communicated effectively about risk in order for people to feel some sort of need to take it. I understand that the researchers did a lot of work preparing for the study, so I don't think it was for lack of trying, but clearly something did go wrong.
But it makes you wonder, is it possible that women aren't that interested in taking something every day for maybe a risk they don't really perceive as that great. Or, I mean, I guess for me, what I went to is an issue that I think is not discussed nearly enough and certainly not studied enough, which is denial, ignorance, stigma. We're talking about a risk that no one really wants to believe they have.
Right.
Right?
Right. Sure.
So what's the play of that in this kind of thing? I mean, that's for me. These are also young women.
Yes,
right?
they're young women. They're sexually active, but they sort of did not perceive themselves to be at risk. So that was what was important. That even though there was focus on that, and that was asked, and if you don't perceive yourself to be at risk and you're perfectly fine, then to take a pill every day that could also possibly have consequences to your health is very hard to do. It's very hard for people to take their malaria prophylaxis when they're in a country and traveling to a country where they're exposed to mosquitoes. It's just hard to take something when you feel fine, and so this adherence issue is even more at play in prevention than in treatment, and we already know it's big at play in treatment. So it was fascinating, actually, and it had verified another trial that we already knew about in in young African women, FemPrep, that showed the same thing. So it's fascinating, and maybe there's the IPREX trial that showed there was efficacy in men who have sex with men. Those are totally different populations.
Yeah. And my fear is that someone would walk away thinking that these interventions, the oral and the vaginal gel, the oral pill and the vaginal gel, don't work in women at risk. And, that's my fear, is that people would do that, when really, for all the reasons that you've highlighted, it seems the larger message is we need to much better understand what women who are at risk want, right?
Yes, because it's not going to be effective if you don't take it. And if people don't want to take it, it won't be effective.
And treatment's taught us that, right?
Yes.
You have to put it down your gullet for it to work.
Yeah.
Right.
It can be
It's
the greatest
very
treatment in the
simple.
world, and if it doesn't get, from here to here, it's not working for
Yeah.
you, right?
Yeah.
Yeah.
But there was an exciting study also in your session about the macaques who were given the depot drug that were 100% protected from.
Yeah, so there was so that same session was focused on prevention, and there were a couple of studies that were interesting around that, which is one, macaques that were given a form of tenofovir they call the prodrug, but it's a little bit different than the tenofovir formulation that was used in these PrEP studies. That when they were given this prodrug that was a little different.
How were they given it?
So it was depot formulated, even though there was also, the one actually I'm thinking of is the
one.
ring formulation.
It was like a
Yeah.
Nuva ring,
Yeah, the
Was
depot formulation was
So
actually with
vaginal
the.
ring.
a vaginal ring.
okay.
Yeah.
So there were two studies. One was with a integrase inhibitor that
Right.
was given as a
Depot.
depot
So
formulation.
So different
like,
class of drug than
different class of drug that had actually ever even been looked at in prevention.
Seems like a nice drug to look at.
Integrase inhibitors, and so this is like dolutegravir put in a form that was really long. So they tried that with macaques, and then the second study presented in that session was the ring infused with this different type of tenofovir, and both showed 100% efficacy basically in the small number of macaques that were then exposed to HIV. But I think one thing that Sharon Hillier said to me as I was actually walking into that session is I said, wow, that macaque data looks interesting. She said, yeah, Pro 2000 buffer gel also looked really good in macaques. So just to remember that like it's not...
Monkeys aren't
it-
people.
monkeys are people.
Very close.
So this is intriguing data, but it doesn't mean, when you take it in the real world. Because tenofovir and FTC looks amazing.
So do you worry about, I guess this is a concern that I have as someone who really, 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 as a positive woman, especially as an activist, really believe women need a prevention tool that they control, that is undetectable, ideally, by a partner, et cetera. I mean, do you fear that we're not going to get there? Particularly with a microbicide, let's say, something non-oral, something that a woman can apply, even a ring. I mean, do you have any fears that the research will slow down, get less?
I think people are very driven towards
Okay.
those targets. People know we can't stop the epidemic if we can't effectively prevent women from
with
getting
more than half
infected.
of women getting HIV now in the world. Right?
Yeah, right.
I
They're
think
the
we're doing
majority.
is-
I think
I
there's a
agree
lot
with you.
driving.
Okay, good.
There's
They're
a
not
lot.
only driven, but I think the ring is exciting, and
Very
the
exciting.
Devivarin ring study has opened, and there it's not really it's not so adherence dependent because it could be
Of course,
fitted,
that's the thing, right?
right? And you don't have to
you
put it
can
in every
insert
day.
it,
You insert
and
it,
leave it there for
and then a month, and then you inserted it. The investigators inserted it again, or the clinicians. So take it away where you have to do something hard, which is hard to take a pill every day or
Yes.
to take, and not coitally dependent, and it's hidden. And I think that's a very exciting idea
Very
with the ring.
exciting.
So I think it may push people more to like, okay, it's all about the ring. So
And
we'll
it does
see.
seem too, there's been other, looks at rings with other stuff in them, but it seems like we really have an obligation to look at all these newer drugs, especially that, like how are we going to know until we keep, I don't know, it just seems like I would hate to call the research now, and that's probably just a fear of mine, hopefully, when it just feels like it's just starting in some ways,
Yeah, and I think that some women, it will be effective to take a pill because some women do want to take pills. Actually, they say that American women are more open to taking pills than African women, and
Who prefer
gels, and American women aren't interested in the gels. So I think with, like with prevention, different strategies will be effective for different people, but obviously this strategy did not work in that population, unfortunately.
Yeah, I mean, we're not a monolith, right?
No.
Just because we're women.
Yeah.
Yeah.
That's not...
Yeah. In fact, maybe we're more complex.
It's a great starting place, but from there it diverges pretty radically, I think, as people, right?
Yes.
We're all
So
in
that's exactly like a variety of prevention tools,
Yes.
right? Like
Yeah.
this does never.
That's
I
right.
totally
Just
agree.
like-
This does not say necessarily that it doesn't work.
I mean, different women like different birth control.
Yeah.
And
Yeah.
so similar to
Exactly.
birth control, there has to be different HIV control measures.
So speaking of hormonal contraception, anything else you saw that...
This has just been such a big issue over now about a year and a half, because what happened is a group led by Renee Heffron had a pretty prominent article in the Lancet ID about in serodiscordant couples, so one positive, one negative, about the idea of what hormonal contraception does in terms of a woman's risk of getting HIV, of a woman's risk, if she's positive, of giving HIV to her partner. And showed that in her study, showed that there were increased risks both ways if you're on hormonal contraception, and specifically the injectable Depo-Provera type.
So that's a longer lasting injection that some,
Which is so
and in
easy.
some parts, lots of women.
Lots of women are on it
Lots of
because then you don't have to do the whole daily adherence to a
Yeah.
pill thing, and it's
Right.
easy and it's available, and so it's really important to figure this out. And so this triggered so much. It triggered meta-analyses on these topics, looking at other topics. It led to a meeting last February in the WHO to say, okay, are we supposed to be changing our policies around hormonal contraception? Are we worried enough about this data? And basically the upshot of that is the data is conflicting. There's methodologic issues when you look at observational data. It's really hard to totally say this is absolutely
It's
true.
like the apples, oranges, bananas problem, right?
Yeah. And we don't know enough, and no, we shouldn't be changing policies right now based on that data set. But we're a little worried, and we should be looking at it more, and we should be thinking of the best way to analyze this data. And then I would be interested in your take on the Jennifer Smith modeling, which is really around but you really need to also be able to give women hormonal contraception, and it's really important also to prevent unwanted pregnancies, which are a high case of mortality.
So they did a very sophisticated analysis, which I couldn't possibly explain, but I knew it was sophisticated, where they were analyzing how many unwanted pregnancies would occur and how many women would die as a result of their unwanted pregnancies.
If you took away this
If
option.
you took away
This
the
is globally, Liz? Sorry.
globally,
Okay.
and actually the number of women who would die in Asia was increased if you took away the hormonal contraception as opposed to having them get infected from the calculated risk of injectable hormonal contraception. And in Africa it probably would have saved some lives. But as one person pointed out, women when they're pregnant are at increased risk of getting an infection, and they did not put that in their model, which would have pushed it more towards hormonal in favor of injectable contraception. And they didn't look at a lot of other factors. They were only looking at those, so they weren't looking at child mortality or anything else besides that. This was just looking at maternal mortality. But I think, it was very important. It was a very sophisticated analysis just to say, you can't jump to a conclusion, particularly in public health measures, from one outcome, because you change that and there's all these unintended consequences that will result. You have to look at the whole big picture. So, I think the bottom line is injectable hormonal contraception works. And the best thing is to get HIV protection that works so that you can have both.
It's funny how logical it seems.
Yeah.
How simple.
Right.
And yet, here we are.
Right.
Yeah.
But we don't have that.
That's right.
We don't have that. And you have to warn women that they're at somewhat increased risk. It's
Possibly
1.5 times maybe. It depends upon the estimates. Some estimates are up to twice as much, twice as more likely. Others are, just 20% more likely.
Mm-hmm.
So, we don't really know how much more likely, but women need to be counseled that this could make them more vulnerable. But really, we just need better HIV prevention.
And their other major message was we also need a variety of contraceptive measures, just like you'd have that same toolkit for lots of prevention measures that you'd want to think about IUDs, which don't increase the risk of viral shedding, and you would just want options. People should have options.
So we're doing something I really don't like to do, which is, when we talk about women, sometimes we're doing the waist to knee conversation, which is really all about a reproductive, potential and so on. But that's where it seems like the news is at this meeting, which again maybe speaks to the need for more research in all kinds of other areas.
Yeah.
I don't know. But there was one very newsworthy item about a baby in the United States born, all I have to say is the baby, and you know what I'm talking about, right? I don't know if one of you wants to summarize it briefly, but I am curious about what your as women, clinicians, and researchers focused on women's health, what if you might have taken things away from it other than the obvious story, which is about does this represent a cure for this particular infant?
Well, I mean,
maybe you could summarize it just briefly, just so people know.
So
if they haven't heard.
Very briefly, a mother went into labor, was discovered to be HIV positive, but gave birth very quickly, and therefore she received no treatment prior to when the baby was born. And the mother turned out to be HIV positive, and the baby was treated with 3 drugs very quickly after infection. And they had documented viral loads multiple times that went down in the child. So the belief is that the child was infected in utero, not while it was being born, but while she was being born, but when she was in utero. But we don't know how long she'd been infected. And then she was on therapy and for 18 months, and then was lost to care. They didn't really give us details, and I think this is one of the sad things about it, is that she was lost to care, but she came back.
Yeah,
and
that's a whole story there, right?
That's
so
a whole story
more
there.
About understand much better for everybody. Yeah.
But then came back into care about 6 months later. Was that?
Yeah, 22 months.
22 months. Yeah. 4 months later, and they tested her, and her viral load, they couldn't detect any viral load. And then that was
2.5 years. So she was 2.5 years by the time that they retested her. So it was longer.
It was longer.
Yeah.
So it was 6 or 8 months. Maybe it was 28 age at 28 months. But anyway, she had been out of care, and then there was no virus that was detectable in her blood, and
the mother had stopped giving her meds. Did you say that?
Yeah.
We don't know if it was the mother or whose care she was in.
Okay, sure.
But yes,
the baby was not
meds.
receiving.
She was not receiving medicine.
And there was a panic that, what's the damage? She's been off meds. She was an infected child.
Yeah.
What's the damage? How high is her viral load? How low is her C4? Mm-hmm. And no matter what, they couldn't find virus anywhere. That was replicating in little tiny fragments. But so it just meant that she doesn't seem to have HIV infection now. And there's going to be ongoing debates about She had a viral load of 22,000 at 30 hours of birth, so there's going to be ongoing debates whether she was really infected, did it see the reservoirs, all that. I think my take-home message was that, number one, there shouldn't be any time that we get to a point that someone wasn't prevented to have, that the mother didn't receive treatment during pregnancy, both for her own health and for the for prevention to her baby. So that needs to be minimized as much as possible, just like it has commonly in this country. And then the second point is, and it's going to raise the debate of this, is when you give what would be called post-exposure prophylaxis after a baby's born, we commonly give AZT alone right now. Should we give more? We don't give AZT alone if someone got a needle stick injury. So we give a 3-drug regimen. And I think that's going to open up this debate, as it should. And that's my take-home message from this. That can't be, there's worries about that.
And they're already designing studies.
Yeah.
I mean, because the people have known about the baby before. So I think it's going to lead to some studies, but we have no idea what really happened with this child. And I hope that people don't think we have a cure for babies, because we don't.
And I think the other important message is, if you have a HIV-infected child, to not take them off meds.
Absolutely.
Because that was a worry that could have come out of this.
Right. I mean, she could have been
for
sick.
women who might have concerns about the impact of the medications on their child, ideally women have a great relationship with a clinician that they can come see and say, I've got concerns about this, or my baby really struggles with these medications, or I don't like what it's doing to their gut, or whatever it is. I think sometimes there's so much pressure, or I fear there's so much pressure without appropriate discussion and partnership. I wonder what the impact of that is.
Yeah.
Yes.
Go home, take your meds, give your baby the meds.
And we don't have any information
Right,
about what was
happening
there, but
So, we're almost out of time. And I wonder, are there things that you wish you would have seen at this meeting? Maybe we have just a moment to just identify what maybe you see as the biggest gaps in research in women in terms of moving us forward. We identified all these places, we're just not there yet. Are there things in particular you wish you would have seen here, or are waiting to see at a meeting like this?
well, I think a problem across the board in research, clinical trials as well as in more basic human studies, is lack of inclusion of women. And one of the issues that I do research on and that I'm interested in is why HIV persists, why the immune response can't get rid of it. And these are pathogenesis studies. And that was a huge topic of interest at the meeting this year. But almost all of those studies had very few or no women in them. And women have lower viral loads than men. Maybe they have different amounts of reservoir.
We don't know what's going on.
People don't understand, and I think that understanding what the differences are could help both men and women. And it's really a sadness that this is not taken more seriously, and ensuring that there's more women.
And really a loss for all of us, because who knows what kind of information could come out that, the more information we get about women, the more information we get about people.
Right.
I don't know about you, Monica. Anything you
Yeah,
wish you would have seen
only
here?
one other comment about that is that even often when women are enrolled in adequate enough numbers to possibly look at differences by sex, those differences are not always looked at. And it's really important to say, hey, was this different in men and was this different in women, if you took the time to enroll enough women. And that it has to be done.
Yeah. So we've got a long way to go. We need more research in the things we've talked about, and even many things we probably haven't talked about, right?
Yeah.
So, same time next year?
Yes.
Thank you both so
Thank you.
much.
Thank you.
Thank you.
Thank you.